Thank you very much. I'd like to thank Mariela for organizing this amazing event. She deserves the applause. This is slightly a different talk for most of the audience here. I'm a pediatric endocrinologist. I also treat young adults with type 1 diabetes, which is slightly a different disease. The concept that you have to understand, everything you've heard about insulin so far this morning comes from normal physiology that insulin is responsive to its environment. Patients with type 1 don't have their own insulin, and they're their pancreas. They have to think for their pancreas and behave accordingly. So, with this said, my disclosures, first of all, I consult for these companies. Nothing is relevant for this talk. I have no nutritional bias, by the way, and I don't have a website. A little bit about the life of a patient with type 1 diabetes. For those not familiar, our patients have what's called a correction factor, which is how much 1 unit of insulin drops their sugar down. And they have a carb ratio, how much insulin they give for every amount of carb that they take. This is a typical example. This is patient A, wishes to have breakfast, and patient A has a correction factor of 1 to 50 and a carb ratio of 1 to 15. So what is the glucose? If you want to correct the glucose, you have to know the glucose. So our patients can use glucometers, and for those of you not familiar, the ISO of these, the standard, allows a 15% error when it's above 75 milligram per deciliter, and that's on a new machine that has not been in school, the swimming pool, the car, the beach, whatever. That's when you take it out of the box. Usually, after a little bit of use, this margin of error enlarges. If you're using a continuous glucose monitor, and Israel is a rich country, most of our type 1s, all the kids almost, have sensors, a good proportion of the adults. This has what's called a mean absolute relative difference. That's not a 15% mistake. That's a 15% mean absolute relative difference, which is a bit of a mathematical way to make big mistakes look smaller, but that's when it's optimal. So patient A got a reading of 200, doesn't really matter if it's the sensor or the meter. So the glucose is somewhere between 170 and 230. That's the truth if we measured it in the lab. So this is a typical winter Israeli Jewish dish. And that's what our patient wants to eat. It's called chamin, for those not familiar, for our guests. Only patient A's mother knows what's inside, what was served, and what will be eaten. So this is a guesstimate of how many carbs are going to be in there. So that's what happens when you eat what we call normal, and this is not actually normal food. This is a typical Israeli snack, highly processed food. It's called bamba, for those familiar with it. And you don't have to count. It says on the box how many carbs are inside. The snack, the small bag, has 30 grams of carbs. Remember, 1 unit for every 15 grams, so this is about 2 units. Now, patient A eats the whole bag, doesn't leave a crumb inside, and doesn't offer anything to anybody else. They finish the whole thing. Now, I don't know if you know, but the EU and Israeli law allows a 30% margin of error in the weight of packed foods. That's the law. So, it's not a medication, it's only food. So if this snack contains anything between 21 and 39 grams of carbs, so now it's time to calculate the insulin dose. Remember, these patients don't have a pancreas, they have to do this calculation all the time. So if blood glucose is actually 200, they would need 2 units based on this carb ratio. If it's 170, it's actually 1.4 units. And if it's 230, it's 2.6 units, and we're not talking about trends and where the glucose is going. I tried to make this simple. For the 30 grams of carbs that they finished the whole thing, as I said, they need 2 units for that too. The carb ratio is 1 to 15. So if the snack has 21 grams, which is probably closer to the truth, it's actually 1.4 units. And if it has 39 grams, it's 2.6 units. So the correct dose is anywhere between 2.8 and 5.2 units for the patient. What additional factors should patient A think about? First of all, where is the injection site? Is it the arm, the stomach, the belly, whatever? It's the same site all the time, or are they transitioning the sites? What's the age of the exposure of the insulin that they're using? I'll talk about that in a moment. What's the ambient temperature? Is it winter? This is not typical Israeli winter. This is sort of fall, or is it summer? Physical activity following the injection, day of the use of the insulin pump catheter. A lot of our patients use pumps. If it's a female, time of the menstrual period, insulin sensitivity is different along the month. If there's any stress, like internal, external stress, diseases, emotional stress. This is Israel. It's a very emotional country. A lot of factors. So how much insulin is the patient actually delivering? Just to give you a taste, this is a paper from Lutz Heinemann in 2017. They later showed the same data about what they checked. They went to American pharmacies, and what they took the insulin vials in a cold box straight to the lab, from the fridge in the pharmacy to the fridge in the lab, and checked how much insulin is actually inside. The published paper is about regular and NPH. They showed the same data for all the analogs, by the way. The FDA says that every 1 milliliter of insulin has to have between 95 and 100 units. But if you look at how much is actually in there, and this is before it went to the Israeli weather, was left in the car, is walking around in your pump, it's somewhere between 20 and 30 units. Just so you know what you're injecting for those in the audience. For the NPH, it looked slightly better. In Israeli weather, this is much more drastic sometimes. Where is the injection site? We know many of them, especially the kids, like to inject at the same spot all the time, and what they get is what's called lipohypertrophy. So lipohypertrophy means that fat is a bit less vascularized, the absorption is lower, and if you take and inject insulin into a lipohypertrophic site, which is in the bright, compared to another site which has no lipohypertrophy, and you look at the concentration, the area under the curve of the insulin injection, they look quite different. But if you do this repeatedly in the same patient, in the same site, you can see the differences in the area under the curve for the first hour, 2 hours, or 4 hours are huge. So if you do this day by day for the same breakfast, you can get totally different profiles that look. The conclusion of this paper that insulin absorption and action are blunted and considerably more variable with lipohypertrophic injection, leading to profound deterioration. So this is totally unpredictable. Now, if you look at the site of the catheter of your pump, for those who have pumps, this is a paper actually done in swine, not in humans, but it's actually the nicest one. They try to differentiate between two catheters, but let's look only at the control catheter. And you look at the same bolus given on day number 1, day number 3, and day number 5 of the catheter. Some patients keep their catheters for 4 or 5 days. And what you see here, and if you look at the maximal concentration of the insulin achieved in plasma and the time to reach this maximal concentrations, you're going to see differences of 25% in the Cmax, 50% in the Tmax. Totally different profile on different days of the pump. So what's the conclusion of this? What should patient A do now? Overdosing will result in hypoglycemia. Underdosing will result in hyperglycemia. So should it be the abdomen, the arm? Is the dose dependent on the day of the insulin pump catheter, day 1 versus day 3? Will the insulin shot work the same in November and in August when it's really hot outside? Does the jogging session that's going to be later this afternoon affect the decision? So the interim conclusions, this is a nutrition, not a diabetes conference. Patients with type 1 diabetes live in a world of 24/7 chaotic decisions made on an hourly basis. Measurement and technical errors are inherent to the process. Even if you do everything exactly like you're supposed to, the results will always be different day by day. The only factor that can be totally controlled is the amount of carbs that you consume. Nothing else of everything that I've mentioned so far. So the lower the amount of carbs consumed, the smaller the insulin dose, the smaller the error. So you reduce your risk of hypoglycemia and hyperglycemia. That's the point I want to try to make first. This is, you've seen this before, this is the ADA recommendations. What should a patient eat? So I'm sorry this is a bit blurred, but the main thing in the 2019 guidelines says that evidence suggests that there is not an ideal percentage of calories for carbohydrate, protein, and fat for all people with diabetes. There's no specific breakdown that like you've seen in the previous talk. There's no data to say that one is better than the other. So are carbs a necessary element for the healthy diet? That's the next question. As a pediatrician, I always ask that. So as you probably know, the healthcare professionals in the room probably know this well, there are 9 essential amino acids and 2 essential fatty acids that humans cannot synthesize de novo, which means you have to get them from your diet. There are no essential carbs. All carbs become glucose at the end. Only red blood cells and the adrenal medulla are glucose dependent. The rest of your body can survive very well from alternative fuels. Now, low carbohydrate consumption may lead to nutrient and vitamin deficiencies. You have to remember that, and those should be supplemented, especially when you're extremely low. But that's not an essential part of the energy process. Can low carbohydrate diet be used safely in children? That's the next question. This is Nelson's Pediatrics. That's the Bible of the pediatricians. That's what we teach the students and the residents in our department. And I have to quote Nelson. Nelson is deceased, but that's written by Kliegman now. The estimated energy requirement does not specify the relative energy contributions of macronutrients. Once the minimal intakes of each of the respective macronutrients are attained to meet physiological requirements and achieve adequacy, sufficient protein intake to meet specific amino acid requirements, fat for essential fatty acids that I mentioned before, the remainder of intake is used to meet energy requirements. Now that's a very important point, which emphasizes that theoretically a child can grow on 0 carbs. If you get enough protein and you get the essential amino acids and essential fatty acids, all the rest is calories that can come from anywhere. So the myth that you need carb calories to grow is a myth. As long as growth is maintained and no deficiencies are present, again, you need supplementation, all is well. So what's a low-carb diet in the type 1 world? How low is low? There are a lot of definitions for this. And as you see, there is an age spectrum. We treat kids up to the age of 18, not 16, and I also treat young adults in the type 1 clinic. We all know what high-carb diet is. That's easy. But a low-carb diet reflects either a percentage of the energy intake or absolute amounts. And from now on, I'm going to talk only about the adult dose of less than 50 grams a day. That's the definition used. Of course, in younger kids, it can be less than 30 because based on their body weight. And the requirement here is for the pubertal process, which is more anabolic. You need a little bit more insulin, so it's 60. So, this was definitions and a little bit of philosophy. Let's go to the data. There isn't too much data about type 1, that I can tell you. There was a systematic review published in PLOS ONE, which is a good journal, about a year ago. And what they showed, that they looked up in all the typical medical literature databases, Medline, MBase, and so on, looked for low carbohydrate type 1 diabetes, and what they first found is about 3,400 papers. After you do a little bit of a triage, and you look at studies that are worth quoting, meaning that there were more than 2 patients, meaning that they actually controlled what the diet was and defined it, meaning that they looked at reasonable outcomes and not only told stories, you end up with 9 papers that are worth analyzing. Now, this is a very busy slide, but what I want to emphasize, which is very nice in this paper, is between FLCD and TLCD, which is false low carb and true low carb. Even if you take these papers that say that they're giving low carb diets to type 1s and you analyze the dietary reports of what they're actually eating, you see that the majority are not low carb diets. And low carb is defined as 100 by some, 130. We're talking about low carb below 50, which is a very low carb, or below 80 or 100, which is low carb, which is not usually what people in this room speak about. When you look about the data in these papers, and they have very nice outcomes, by the way. You have hemoglobin A1C, which is the holy grail, used to be. You look at severe hypoglycemia, you look at total daily insulin dose, and you look at BMI. So what you actually see, that if you look, there's usually, most of these are not randomized. There is a pre and post, before the diet, after the diet. And what you see that within group or between groups, most of them don't show anything. The only 2 that are actually quite nice are the true low-carb diets here, which are very low, less than 50. They show a nice effect on hemoglobin A1C, no effect on anything else, maybe on the insulin dose, which is, the data here is, I would call soft data, not something you wish to quote. And there's significant heterogeneity of the included studies. The overall effect could not be determined. The review presents all available evidence on low-carbohydrate diets for type 1 and suggests an urgent need for more primary studies. A little bit from this year, this is a very nice study. This was done by Kristen Norgard. The Scandinavians like low carb in type 1, published, sorry for this typo here, but if you look at the numbers, this is 14 patients. What they did, they randomized a crossover trial for 12 weeks, 3 months, which is the usual interval between meetings in the clinic. They do a low carb and a high carb, a washout of 3 months, switch teams, the high carb become low, the low carb become high, and then they end up with their patients. Included 14 in the analysis, so what you see here is 7 and 7 on each group. This one dropped out, this one dropped out, 2 dropped out here, but you used their data anyway. Low carb was defined as less than 100 grams a day. That's not real low carb. High carb was more than 250. 12-week washout, as I said. All of them had sensor-augmented pumps. Now what you see here in the analysis, this is the low carb, which is, let's say, not exactly a kosher low carb. And this is the high carb. What you see, we now talk about time in range. We want our patients to be in the range. There is no difference in the time in range. But what you see is less hypoglycemia on the low carb diet, which is nice. We don't want our patients to be in hypoglycemia. You look at the variability of the glucose, and obviously there are less fluctuations in glucose levels, which are highly significant, which is nice. Glucose variability is a very popular theme in diabetes conferences these days. It's hard to define how important it really is, but there is some importance to it. Obviously, insulin doses go down on low-carb diets. Their conclusions, if you compare an intake of 250 grams of carbs to a restriction of 100 carbs, which is not very restrictive, in adults with type 1, you reduce the time of hypoglycemia, you reduce variability, and you also lose a little weight. I didn't show you that, and you have no effect on cardiovascular risk factors. Now, this is a short report that came out again this year, and this is from the Australian group, actually, by Pierre Fournier. And they show the glycemic benefits of a very low carbohydrate ketogenic diet, which is something I'm going to mention later, in adults with type 1 diabetes, and they raise a few red flags. Now, these are the lines. These are interstitial glucose. They put a different kind of sensor, but this is continuous data in a small number of patients. And what they actually showed is the obvious. This is the first study to provide evidence that very low carbohydrate, high fat, ketogenic diets may be associated with an excellent A1C. I think everybody in this room knows that, clinicians and patients alike. This study provides evidence that ketogenic diets may be associated with some ill health effects, such as dyslipidemia and increased hypoglycemia risk. I'm going to mention that later. Now, this is a paper that came, which received a lot of publicity from David Ludwig, who's a good friend of mine, and I think actually did the community of the low carb for type 1 at least. I think this caused more harm than good, because this paper actually went to a Facebook group of people that follow type 1 with low carb diet and sent questionnaires. And initially, out of 1,900 people in the group, they received responses from about 500. About 400 were eligible, 340 consented, 316 included in the analysis. And if you look at confirmatory medical data, you end up with 138 out of 2,000. That's called, in Hebrew, selection bias. You get the best of the best patients to give you the results. Can you count on this for anything? Probably not. But the good of the paper is that it raised the awareness that this is possible. And this started gaining acceptance. Now, what they showed that the distribution of A1Cs of their patients, the pediatric are the darker ones, the adults on the brighter ones. You see very nice A1Cs. Again, there's no control. Anybody who works in the clinic says, like, I have patients come in, oh, yeah, I do a low carb, but I eat fruit and drink milk. That means they don't eat bread, but that's not low carb. We don't really know what's going on in people with an 8 A1C that say that they're eating low carb. But again, these are very nice results. You don't usually see, at least in pediatric clinics, so this is nice. It actually invites a lot of criticism because of the methodology, but it raises the issue. So they show exceptional glycemic control, very low adverse events. Is this generalizable when you have only 100 patients with confirmed data? God knows. A little bit of, this is data from my clinic, just to show you that these things are possible and can be done. This is an output of a Dexcom sensor. This is a female, she's 32 years old. She has type 1 diabetes for 16 years. She's on multiple daily injections, uses Triglycerin as a basal, and uses RN, an analog. And she eats less than 30 grams a day. That's a very low carb diet. Now, what I want you to see here is that the time in target is not the time in target that is usually used for diabetics. We want diabetics to have between 70 and 180. This is 60 to 140, which is a normal person without diabetes. And this lady, which I have a suspicion is in the room, is more than 99% in range, which probably most of the non-diabetics in the room are not. So she deserves the applause. If you look at the hypoglycemia, practically she's not in hypoglycemia. Now, when you look at the average glucose, for those who read Dr. Bernstein's book, we want to be 83. This is a 3 months data. She's 83, which is nice. Her calculated A1C is 4.5. I'm going to mention something about that. I'm not a big fan of these. And her variability is very low. So this is possible if you do it right. This is another patient. This is another way to look at this data. This is a 38-year-old male, again, on multiple daily injections, not on a pump, uses Trigludic and regular insulin, eats about 30 to 40 grams a day. He's much bigger than the previous patient. If you notice the way, this is 6 months of data, 7 months of data actually, and he doesn't allow himself to cross over 130. He defines 130 as hyperglycemia. And when you look at this data, this is, notice the y-axis, not what you typically see. And below 70 is the hypoglycemia. He's rarely in hypoglycemia. And sometimes he's 4 to 3% over 130. He's never over 150. This guy walks around with a 4.8 or 4.9 A1C. This is doable. This is the low hypo. This is actually a 3-year-old, which I saw in clinic a few weeks ago. Type 1 diabetes since the age of 12 months on a sensor-augmented pump. About 40 to 60 grams of carbs a day, which is not a little bit more than we're used to. Hemoglobin A1C is 5.5. You see these excursions. You always have that with little kids that sometimes steal little food. Sometimes the pump is in the daycare. Somebody pulls your pump. A lot of accidents happen in kids. But this is possible in very young kids. Of course, he's growing very well, a very nice kid. It's possible to do this. So about low carb in growing children, it's a family affair. You can't take a child. In Israel, we have the average in Israel is more than 3 kids per household. You can't say this child is going to eat low carb, no bread, no snacks, no fruit. The rest of the kids are going to eat shawarma and a pita, for those who know what that is. That doesn't work. If the whole family gets into this together and everybody eats the same, this is possible. Adequate protein and total caloric intake should be maintained. If the child is a picky eater, it's usually non-sustainable. Insulin is an essential growth factor, so there's a limit to cutting down on the doses. It's not, having a 10% higher insulin is not the point here. Vitamin supplements should always be provided to these children. And the best monitoring, as in most pediatric conditions, is through the standard growth charts. If the child is growing well in height or length and in weight, development is okay, that's good. Now, we know, especially in pediatrics, that's also true for young adults, restrictive diets may backfire. We know that especially adolescents with type 1 diabetes, regardless of their diets, especially the females, have a very high percentage of eating disorders. That's been published years ago. Now, close psychosocial monitoring is a must for people who follow this at any age, specifically in children. It's not all about the glucose. I want to make this point. We're treating humans, patients. If you come with a flat line like that and a 4.5 A1C and you're miserable and depressed, that's not a good diabetes treatment. I would say be more liberal, eat more things, and cheer up. I don't give my patients the applause for having good numbers. I want them to feel good, behave well, be active, and be happy with their lives, and be in good control. It's not worth it being with a 4.8 A1C if you're miserable all day. A little bit about the lipid dynamics, and this is important. This is based on our own clinic observational history, and I hope Mariella has this meeting in another year or year and a half. I'll have actual data to show you. This is just an observation. When you go on low carb in type 1 diabetes, usually your triglycerides go down and stay down, which is good. Your HDL cholesterol goes up, usually stays there. Sometimes it goes back to its previous level before you started on a low-carb diet. How protective this good cholesterol is arguable, but that's what happens. The LDL is the bummer here. Now, most patients, when they go on low-carb, follow this path. They have a baseline level of LDL, which goes up significantly 3 to 6 months, and usually stabilizes over 9 months to a year and comes back to its basal. Some of them go up and stay very high. Now, we don't need Ansel Keys to tell us what's a high cholesterol. The bad lessons about high cholesterol were learned from, like everything else in medicine, from the extremes. They come from familial hypercholesterolemia patients that have thousands of the levels of LDL are in the thousands, but actually the heterozygotes, which are the carriers, have LDL levels in the 200, 300, 400s. And these are the guys, we know what happens to them when they're 30 and 40. So once you're in the mid-hundreds, I'm not sure the American Heart Association that wants you to be at 70 or 90 now, every day it goes down, I'm not sure that's where you have to be. But when you're in the high 200s and 300s, we know that's a bad idea. We don't have to prove that. So, lipid profiles on the low carb, initial rise in total cholesterol, HDL and LDL, along with a decline in TG. Some will normalize the LDL to their baseline before the diet within about a year. Some will not. No data on LDL particle distribution on low-carb diet in type 1. We'll have that data in about a year, by the way. The response to a low-carb regimen is individual and should dictate additional management. This has to be done under supervision. And if somebody wants to read this, just I was showing the reference about the nutrigenetics of blood cholesterol concentrations towards personalized nutrition, how different diets in the same patients get totally different results. Now, I know this won't be popular in this room, but I have to say this anyway. Nutrigenomics and nutrigenetics are two sides of a coin. That's the nutrition of the 21st century. Now, the nutrigenomics said that some food components may interact with your genome, and that's true for all of us. And the nutrigenetics part of it says that some genome profiles are going to affect how you process the food that you're eating. So when you put all the people in the front line here on the same diet, you're going to get a totally different metabolome in their blood, and the effect on their DNA and RNA is going to be totally different. You have to know that. So I'm not going to get into the rough details, but when you eat a hamburger, it's going to affect differently everybody in this room in regards to their DNA, in regards to their RNA in translation, the proteins that are produced in response, and the metabolome that we measure in the blood. And that determines the health effect. There's no one size. You can't say, we're going to put all our patients on this, all our patients on that. In the 21st century, I would say we're almost in 2020. It's November. It's naive to assume that a specific diet fits all those with a specific medical condition. And naive is an understatement. It's practically wrong. You have to follow the patient, see the responses, see the results, see the risk factors, as you call them, see what happens, and suit the diet to the patient. The food is still the medicine, but it has to be tailored to the patients. What about ketogenic diet? Now, ketogenic, we usually define ketogenic as below 50 grams, but that's if you have a normal pancreas. We have to remember that patients with type 1 diabetes are their own pancreas. They deliver insulin subcutaneously. They by definition have higher insulin concentrations than if they had a normal pancreas, because it's not delivered correctly and it has a lot of technical problems with it. So why is VLCD called ketogenic? Because free fatty acids are secreted from the fat and oxidized in the liver to produce ketones. We've heard about all that. Oops, I'll finish in a moment. Shh. This is true for people with a functional pancreas, and my patients don't have a functional pancreas. Adipose tissue, liver, and muscle have different insulin sensitivity, and adipose is most sensitive. If you want to break down fat, you have to be at the most minimal insulin concentrations. This means that only a minimal insulin concentration allows ketogenesis, and the fine balance is easily maintained if you have a pancreas. I like ketogenic diets for people who want to lose weight or have a functional pancreas, but this puts the patient with type 1 diabetes at significant risk. We heard in the morning that the ketone level, which is different between ketosis and ketoacidosis, is a 1 order of magnitude. But the difference in insulin to achieve that in a normal person is about 10–20%, not more. That's all the difference that you need if somebody is insulin sensitive. Now, when you don't deliver your insulin on time, or if suddenly you're more insulin resistant because of some trivial infection, stress, this watch clock, or anything, if you don't respond accordingly, you put yourself at risk. So low-grade ketosis is a very risky nutritional strategy for patients with type 1. Low carb is smart. Ketosis is not that smart in this condition. So I'll finish with this. The potential pros of the low-carbohydrate diets: reduce A1C, reduce variation, maybe weight loss, probably, reduce the total insulin dose. There is a risk of nutritional deficiencies. You had to add supplements to the patients. The risk of ketoacidosis, nobody has quantified this, but I've seen it happen, and it's nasty. I wouldn't try that at home. Reduced response to glucagon. That's an important point. When you're on a very low-carb diet, your glucagon stores are low. When a patient is unconscious with hypoglycemia, the emergency treatment is glucagon, and the idea is to break down glycogen with the glucagon, but if you don't have enough glycogen, you are in Israel, only he is going to help you, not your glucagon. He or she, depends on what you believe. Risk of preoccupation, I mentioned that. It's hard to sustain this. It's quite an expensive diet, by the way. Conclusions, based on the literature and my personal experience, a low-carbohydrate diet, which is high protein and smart fat. Now, I know maybe this is not popular in the room, but when I say this, I'm stepping in the footsteps of giants such as Dr. Bernstein, who was the pioneer in this field of type 1. High protein, smart fat is an excellent strategy to maintain good metabolic control. In my patients, dose adjustments should be planned before you start. You have to reduce the insulin, and you should never, ever take it with an SGLT1 or 2 inhibitor, which are allowed in Europe now. Low-carbohydrate diet should be individualized and adjusted to suit individuals in order to optimize adherence. Low carbohydrates are not suitable for all diabetics due to adherence, cost, and genetic background issues, and there is no one-size solution for type 1, type 2, or any diabetes. They can be practiced safely in children with appropriate precautions. Patients on strict LCD should have vitamin supplements. LCD should be offered as an option to every patient with type 1 diabetes, in my opinion. The spectrum of LCD is suitable for some, but not all patients. It can be 30 grams a day like Bernstein, it can be 50, even 70 and 80 isn't so bad to achieve good control if that's what you need. And there are several RCTs on their way, and I'm sure in a year or two you're going to have much nicer data. This is, I hear you, this is Haifa for our guests. This is where I come from, and this is where I work. And just my last slide, this just came out about 2 days ago, and I urge everybody in the room to read this. It came in a Journal of Clinical Lipidology. It's an excellent review and a scientific statement, which gives all the data very objectively, not very anti, and I think everybody will enjoy it. Thank you.